Hi, my name is Tanner and I'm a registered respiratory therapist in the medical intensive care unit. I just returned from a 2-week vacation. I am taking care of a mechanically ventilated patient with emphysema. Her name is Mrs. Tubbs. She's lived with a diagnosis of chronic obstructive pulmonary disease for almost 10 years. The attending physician wants to be very cautious in the weaning and liberation of mechanical ventilation for this patient, as it has been difficult in the past keeping Mrs. Tubbs breathing spontaneously after previous extended stays on the vent. My role in successful weaning and removal of positive pressure assisted breathing will consist of performing an arterial blood gas for ventilation and oxygenation, checking her bedside ventilatory parameters such as her vital capacity, NIF, and making sure that her blood pressure and heart rate are within normal limits, verifying that the underlying disease process has been cured, and turning off the sedation before the spontaneously breathing trial. My role in keeping Mrs. Tubbs off mechanical ventilation after extubation will consist of keeping the head of the bed elevated, bronchopulmonary hygiene techniques, lung expansion techniques such as incentive spirometer, BiPAP if needed, and any bronchodilators, PRN if she needs any. So we are currently in the management phase of mechanical ventilation with Mrs. Tubbs. With her being a COPD patient, her blood gas is going to look different than a normal blood gas. Her pH is going to be around 7.34 to 7.37. Her CO2 and PaO2 are going to be the same from 55 to 65. Her SATs are going to be anywhere from 88 to 92. With a COPD patient, you don't want their SATs to get over 93 because they will become obtunded and alter mental status. Some special precautions that I will consider while weaning to minimal ventilator assistance will be on the ventilator will be the waveform pattern. Make sure that she is not auto-peeping. Making sure that on the spontaneous breaths that she's taking in SIMV are good volumes for when we bring her down to a lower rate. I will make sure that her heart rate up on the monitor is within normal limits and she's not tachycardic. Also, her SpO2, I'll make sure when we bring her down stays within her normal range. And the end tidal CO2 can give me a good observation of a non-invasive way to measure her ventilation. Also, her use of accessory muscles, if she starts using neck or chest muscle strains, I can see that she's uncomfortable and getting agitated with the changes that we make, so I'll just pay close attention to any changes that we make on the vent if she becomes uncomfortable with any of them. So we are currently in the management phase of mechanical ventilation for Mrs. Tubbs. Some special precautions that I will consider while weaning Mrs. Tubbs to minimal ventilator assistance will be, number one, checking her oxygenation and ventilation with an AVG. And with her being a COPD patient, her AVG will be different than a normal person's blood gas. Her pH will be from 7.34 to 7.37. Her CO2 and PaO2 will be from 55 to 65 torr. Her bicarb will be from 28 to 34, and her SATs will be around 88 to 92. With the COPD patient, you don't want their SATs to be above 92 because they will become obtunded and their mental status will change. Some other precautions that I will consider will be her vital signs such as her heart rate, making sure that she's not bradycardic or tachycardic. Her respiratory rate, making sure that she's not breathing too fast before we bring her down to a slower rate. Making sure that her spontaneous tidal volumes are appropriate and that she's pulling good volumes on SIMV. Making sure that her blood pressure is within normal range, and making sure that she's not using accessory muscles around her chest or neck, and that she doesn't look agitated, and that her mental status remains the same when we bring her down to minimal settings. So Mrs. Tubbs is currently on the following mode of ventilation. She's on volume control, SIMV. Her set tidal volume is 450, and her set rate is 10. Her total rate is 13, so she's breathing 3 over the vent. Her pressure support we have set on 5. Her PEEP is set on 5, and her FiO2 is 35. And her spontaneous breath, right now it's measuring 359. She's been around 250. And so her vital signs are stable and normal for her age and cardiopulmonary disease history. Her SpO2 is around 91, and that's where we want her at having COPD. The range is 88 to 92. And the attending physician wants me to bring Mrs. Tubbs down to a rate of 4. And instead of just dropping her down all at once, I'm going to bring her down in increments of 2 every 30 minutes. And I will check her FiO2 and PEEP, and I'll manage those settings depending on her saturation, maintaining a range of 88 to 92. And her pressure support I will keep at 5 depending on her work of breathing, and I will increase that if I need to. I will assist her at ventilation and oxygenation with an ABG to get an accurate reading. And non-invasively, I can look at the end tidal to read her ventilation, and I can get a reading on the SATs by her pulse ox. And some other assessment skills that I will use will just be my typical bedside assessment skills. I will listen to her. I can just look at her and see that there's no nasal flaring, that she's not using accessory muscles, she doesn't have an increased work of breathing, she doesn't become cyanotic, and that she's just comfortable when we make these changes. See, you probably see me wearing this. Well, the nurse just told us that Miss Tubbs is on precautions, but we don't know what for yet. So I figured I would put everything on. You can never be too safe. So I have Mrs. Tubbs successfully weaned to a SIMV rate of 4. I'm about to place her on pressure support with a pressure support of 5 and PEEP of 5. And I'm going to put her FiO2 at 35. After about 1 hour, I will get normal weaning parameters, and I will start off with her tidal volume, which is just a normal breath in and out with normal breathing. And a spontaneous tidal volume will be what the patient is breathing in and out. And we want that to be greater than or less than, or greater than or equal to 5 milliliters per kilogram of ideal body weight. And then next I will look at the respiratory rate, and we want that to be less than 30. Normal range is between 12 and 20. And then next I will look at the Tobin index. And with a patient on the ventilator that can't tolerate independent breathing, they tend to breathe fast and slow, and they will have a higher Tobin index. And we usually want it to be less than 100, and that's considered normal. And vital capacity, we want that to be greater than or equal to 10 to 15 milliliters per kilogram of ideal body weight. And what that is when the patient takes, when they exhale the biggest amount of air they can after taking the biggest, deepest breath in. And that's one of the pulmonary mechanics that we use during the weaning period. And then another pulmonary mechanic measure that we use is the NIF. And we want them to have negative 20 or less. And that tests their respiratory muscles, so we can see if they can protect their own airway, and if they can cough, and if they're strong enough to protect their own airway. And next I'll look at just non-invasive ways to look at the oxygenation and carbon dioxide values. And we want it to be greater than 88% on the oxygenation, and we can test that with the pulse ox. And then on the carbon dioxide values, 40 is the typical normal range we want to see on that, and I can detect that with a CO2 end tidal detector. All right, so we just extubated Mrs. Tubbs to a nasal cannula at 2 liters, and she started desatting to 82 almost immediately. She's had increased work of breathing. I believe that she's performing a rapid shallow breathing. So I would expect her ABG values to be acute alveolar hyperventilation on superimposed chronic ventilatory failure. So her pH is going to be increased. Her CO2 is going to be increased. Her bicarb is going to be increased. And her PaO2 is going to be decreased. So I talked to the doctor and I shared my findings with him, and he decided that Mrs. Tubbs needs to be put on a BiPAP machine. So first, I need to fit the mask. I need to get the right size mask, and I'm going to use this size chart to see what size that she needs. And I'm going to fit it to her face, and it looks like that she needs a medium. So I will get a brand new medium mask. I will put this on. Take off this cannula. Alright, we're going to put this on. So, some considerations between a nasal mask and a full face mask. I chose a full face mask because she's mouth breathing, and a nasal mask wouldn't do any good in this situation. So, some initial settings that I'm going to set on the BiPAP machine will be 10/5 just to start with, and then get a reading from there. And I will set her oxygen at 60 because she's COPD. We don't want to be giving her 100%. I can increase the EPAP if I need to, and boost her oxygenation that way. Some initial alarm settings that I will do. On the pressures, I will go 10 above, 10 below. And on the apnea, I will do 20 seconds. On the minute ventilation, I will do 1 above, 1 below. And on the rate, I will take the rate and times it by 1.25. And her rate we have set at 16. So I will take that and times it by 1.25. That will be 4. So I'll set the high rate at 20, the low rate at 12. And the way that I will monitor Mrs. Tubbs and see if she gets any better, I can get an ABG and get a very accurate reading on her ventilation and oxygenation. Also, just using my bedside assessment and seeing that she has a decreased work of breathing, and if she has any mental status changes. And I'll get you close so you can see the alarm settings. Right here, and this is the monitoring. And this is what we have her set on right here. Mrs. Tubbs' respiratory status begins to deteriorate on BiPAP. After getting an ABG, she is in respiratory acidosis. So her CO2 has increased, her pH has decreased, and her PaO2 has decreased. Some acute changes that I have witnessed with her is an increased work of breathing. She's become lethargic. She's pale. She's using accessory muscles in her neck and chest. And some deciding factors whether or not to call rapid response in the future will be her respiratory failure. right when we extubated her, her SATs dropped straight to 82%, and she became tachypnic right away. So I've initiated rapid response, and while I'm waiting, some things that I can do is just assess my patient, check her oxygen, heart rate. I can make some changes on the iPad with the doctor's order, and I can start getting my intubation tools ready for when they get here, so I'm set up and everything goes smoothly. So some intubation tools that I'll need are a couple sizes of ET tubes, one above, one below, and have the stylet ready in it. And depending if you know the doctor's preference, you can kind of shape it to how he wants it. And before you give him the ET tube, you actually want to make sure that the cuff works on it. So on a brand new bag, you would just barely peel it open and just inflate it and then deflate it and make sure that it works. You have your laryngoscope with the Mac blade. You also have a Miller. You have your CO2 detector. You have your anchor fast to hold the ET tube. You have your ambu bag. And also you need to make sure that they're sedated and before being paralyzed too. And also have a bougie just in case.